See how everything we learned this morning, we put it together for clinical practice. So I'm very pleased to be chairing this symposium with my friend Rohit Loomba. And the way this has been set up, we'll both have a case that we will discuss. We'll start with a case mostly about diagnosis, finish with a case about treatment, and then we will have a discussion between you and me during the presentation of these cases, and then we can have a collective discussions with questions from the audience and answers after we're done with the two cases for a total duration of 1 hour. So thank you very much for being here. Maybe we can close the doors and we can have the first slide with the first clinical case. So first slide, those are our disclosures, kind of asymmetrical, I would say. Okay, next slide. So do you want to explain the learning objectives?
Sure. The learning objectives for today's CME are identify non-invasive tools that optimize diagnosis, staging, and monitoring of MASH, develop treatment plans that incorporate recently approved and available therapies that target MASH and comorbid medical conditions, and then describe recent advances and ongoing research in MASH diagnostic and pharmacologic treatment options. So approximately how many patients with MASH do you see per week in your practice? And these are some of the options. Again, there's no right or wrong answer, so please go ahead and respond. You have a teleresponder on your desk. And let's see.
Do we need to move the slide forward?
Okay, good. So rules of the game. Everyone has been assigned to a team based on their table location. Dr. Ratziu's team represents the team yellow, and my team represents team green. So let's see who are in team green here. Okay, we got to win. Okay, that's good. The team who has the highest percentage of teammates who choose the correct answer will receive 10 points, and the score will be added cumulatively throughout the program to determine the winner. So go Team Green.
Okay, so thank you, Rohit. Let's see how this works out. So the first part of the symposium is about managing advanced fibrosis in patients with MASH. And we'll take the example of Christina, which is a 73-year-old Latina woman, has a BMI of 26 kilograms, so slightly overweight, increased ALT and AST, as you can see, high levels of liver stiffness measured by transient elastography, a FIB-4 score of 2.0, LDL cholesterol within the normal range, no hypertension. She does have a family history of cirrhosis. She does not take any medications or have any comorbidities. And she has been diagnosed with abnormal liver enzymes over the past 3 years by her general practitioner, but nothing was done specifically about that. So obviously, when you look at these type of chronic liver disease, the most important thing to understand in terms of what will happen to the patient and what is his risk is to know the stage of fibrosis, how much scar is there in the liver, because the more fibrosis, the more deleterious the prognosis will be. And now we have a lot of studies that have looked either retrospectively or prospectively into the impact of the fibrosis stage defined histologically and the prognosis in terms of liver-related events or all-cause mortality. And you can see that all these studies are convergent towards showing that the more fibrosis, the higher the liver-related mortality and the higher the all-cause mortality. So one of the things that is important when you look at this type of data is to understand if there is a threshold starting which you have an increase in the probability to get liver deleterious outcomes. And all these studies have shown that starting stage 2, defined by the NASH CRN, there is an increase in the probability of developing liver-related events. Now, that doesn't mean that people who are only at stage 1 are off the hook. Actually, I believe that if you have longer studies over several decades instead of just less than 1 decade, and if you have higher number of patients, I bet you can demonstrate that stage 1 fibrosis is associated with all-cause mortality and liver-related mortality as well. And the other thing that is important to understand is that beyond fibrosis, the level of activity of the disease probably modulates that risk. In other words, there are people with stage 1 fibrosis, but very active disease and very high level of insulin resistance that probably are at higher risk than just the regular stage 1 patients. But given this data here, what becomes very important to understand in a case like the one of Christina is what is the stage of fibrosis. So therefore, in order to, if you want to avoid a liver biopsy, you would have to rely on some non-invasive indicators of fibrosis. And some of those are listed here. And the question becomes, which one are really important for you in your practice? Which one do you rely or which one do you trust in determining how much fibrosis is there in a patient like the one we're commenting upon today? So is it FIB-4 score? Is it transient elastography? Is it the PNPLA3 genetic mutation? Or is it the ELF score? So let's go ahead and vote. Okay, so I guess we have the answers at the end of the presentation. Oh, yellow wins. Good.
Congratulations,
right.
Team Yellow.
Thank you.
And Team Green, please wake up.
All right. So which factors influence your choice for the combination of NITs to stage fibrosis for Christina? If you look at, obviously this question becomes more and more urgent because of the approval of Resmetirom. So you have to do something in clinical practice now that you have at least one drug that could be used in this condition. So you'd have to select patients for being treated with this drug. But the selection process is not easy because you have to identify patients that have the profile of those included in phase 3 trials, which is active NASH plus stage 2 or 3 fibrosis, but that do not have the profile of cirrhotic patients because the drug is not approved in cirrhosis. So you have to find that window in the fibrosis spectrum that you could identify more or less reliably with non-invasive tests to be sure that you're including cirrhotic patients, you're not including patients that are too early in the fibrotic process. So in order to do that, obviously, you first have to make sure that other causes of liver disease are absent. And then you can rely on a combination of non-invasive tests to determine whether you're at stage 2, 3 pre-cirrhotic or whether you're already beyond that at a cirrhotic stage. And this is all listed here. So in relation to the question that we just asked, transient elastography, definitely. MRE, if it is available, also. The ELF score, whether you do it alone or in combination with another marker, the level of certainty can be different. And then you have these combined panels which have been designed to identify active fibrotic NASH, which is actually the profile of patients included in these trials, and which are basically FAST, MAST, and MEFIB. Rohit, you developed MEFIB. Mazen developed MAST, and Phil Newsom and all the other investigators developed FAST. Those are panels that incorporate liver stiffness measured either by FibroScan or by MRI, plus AST or FIB-4 in order to classify patients at risk, high or low risk of having advanced at-risk MASH. So you need to make sure that you exclude cirrhotic patients from being candidates for resmetirom therapy, and that would mean that you would have to exclude all of those that are above 20 kilopascals or an MRE stiffness value above 5 kilopascals or ELF score above 11.3 and all the other things that are listed here. And once you have identified a patient that is within the stage 2 or 3 window and not already at the cirrhotic stage, then you can consider treatment with resmetirom. Now, it is interesting because you would either have the possibility to rely your identification process on fibrosis alone, or, which is not what was done in the pivotal trials testing these molecules, or you can rely your identification process on identifying at-risk MASH, which is active fibrotic MASH. Now, all the biomarkers that we discussed, transient elastography, MRE, FIB4, ELF, are not designed to identify active fibrotic MASH. That's why a certain number of biomarkers, which I already alluded to, have been specifically designed to identify these patients. And they all work more or less well. This is a head-to-head comparison that has been published recently. It comes from a large population of diabetic patients with histologically documented MASLD. But the point here is that the thresholds that we use for diabetic patients might be different from the ones that we use for the non-diabetic population. And you can see here the comparison of the diagnostic value of these different measures. So we have plenty of different NITs to use in order to identify which patients would be eligible to resmetirom therapy. It is still unclear whether that process should only rely on fibrosis or should rely on the genuine profile of active fibrotic MASH, which was in the pivotal trials. All of these tests are described here, and you can see that they have limitations, obviously. The NIS2 plus is a serum biomarker, so it is different from all the other ones. It does not incorporate liver stiffness, biophysical measurements. It's a purely independent serum-based biomarker. It has only been validated in a very large but unique data set of patients from a phase 3 trial of elafibranor. So it performs very well in the NIMBLE consortia. Some data has been shown today from a clinical trial with this biomarker as well, but basically has not been validated outside that set of individuals. So this brings us to the question of how many patients that you would thus identify with steatohepatitis and stage 2 or 3 fibrosis. In how many of these patients would you currently initiate treatment with resmetirom now that we have this treatment available in clinical practice? Okay, so everybody wins. Okay, we still have 10 points advance over, but this was, okay, I guess the explanations were quite clear. So now we go to another question, which is, once you have identified these patients, do you have any reluctance in using resmetirom? In other words, would you put all patients on treatment or only a fraction of those patients that are eligible? This is an important question because, you know, we've been waiting for so long for having a drug. Are we using it? I hope we can keep the lead. Okay, yeah, good.
It's narrowing. I think
It's
people are waking up.
Okay, so moving ahead.
Do you guys know that you're in Team B? You heard the
Yeah, they have
team? And those two, you don't have a transponder, do you? Okay, you got to use it.
Okay. No excuse, Rohit. We're leading. We're ahead. So once you decide to use resmetirom, obviously the next question is, how long do you treat and how do you make sure that the drug works? And what we will show you here is some sort of consensus statement based on data available so far. So we'll have more data in the future because the resmetirom trial continues. But based on data accumulated so far, those are this is the guidance from the ASLD, trying to put a little bit some sort of flow chart to determine when you should stop therapy. So the whole point here is that not everybody is a responder. Obviously, we did not reach 100% response rate. So some people are non-responders. When do you determine that those people are non-responders? How long after initiating therapy is one question. The second question is, how do you determine that? So in order to answer that question of futility, you would have to rely on non-invasive tests. Since biopsy was not necessary to initiate treatment, it won't be necessary to determine whether treatment is effective or not. So you would have to rely on non-invasive tests. And you therefore need to know, given that all these tests have a lot of variability, when are you sure that the drug is working? When are you sure that the drug is not working? And how about in the middle? So what is being recommended by experts from the ASLD is that clearly if you have a strong response, more than 25% of transient elastography on liver stiffness measured by by FibroScan, if you have a response by at least 20% drop in liver stiffness as measured by MRE, if you have a strong reduction in ALT, we've seen this morning what strong reduction means, 30 to 40% from baseline levels, then probably you have a good response to the drug and you should continue. On the opposite side of the spectrum, if NITs get worse after 1 year of treatment, if there is no clear decrease in ALT or if there is an increase, something clearly is not working and you would have to stop therapy. Importantly, you have to determine that after 1 year of treatment, because not because the drug doesn't act before, but because these NITs are not sensitive enough to change earlier on in terms of reflecting fibrosis. They do change early, but that does not necessarily reflect fibrosis, as we discussed this morning, by reflect inflammation and so on. Now, the problem is if you're neither in the green nor in the red box, and I suspect, we'll see, but I suspect many patients will fall into that. Yeah. So you have some level of reduction of liver stiffness, of ALT, but not to the extent that is mentioned in the green box. What do you do then? I think you would have to give the drug the benefit of the doubt and continue, and then reassess maybe 1 year later. So in this patient, the PNPLA3 test was performed, and it confirmed the bad phenotype, the one that is associated with more cirrhosis, more inflammation, more liver cancer, which is the GG phenotype. And then the question becomes, how does that play into, first, natural history of the disease, second, response to treatment, Resmetirom. So we know that this genotype here is bad for liver-related outcomes, but there are some data regarding extrahepatic events, and some limited data show that there might be a protective effect against type 2 diabetes, and it might be associated with a prothrombotic status. This is very preliminary evidence from some isolated studies so far. Now, in terms of whether the genotype, PNPLA3, precludes or favors response to therapy, I think that question is a very important question, given the role that this genotype plays in the natural history. But it is a question that will not have the same answer depending on what type of drug you're using. So, for instance, for tirzepatide, it has been shown very recently, based on the phase 2b trial that was presented this morning, a reanalysis of that trial, that MASH resolution is actually greater for people who have the wild type, CC genotype, the good genotype, versus those that have the bad genotype. But fibrosis improvement is similar across genotypes. Data from Resmetirom did not show a difference between genotypes. So this is really a crucial question for future studies. It might be that people who have the mutations might have a different type of disease than those who do not have the mutations. I'm sure Rohit will comment on that. It might simply be that the combined effect of the mutation and obesity and diabetes make that really puts people at risk. So there might also be an interaction between innate and acquired factors. So the genetic risk scores that are based not only on PNPLA3 but on other genotypes associated with natural history in this disease, you can build a genetic risk score that can help at least predicting with more accuracy what the fate of the patient, and maybe it will help predicting the effect of the drugs in development. So PNPLA3 risk does not affect response to Resmetirom, and based on the very important role that these polymorphisms plays in the natural history of the disease, quite naturally, a lot of drugs have been developed and are now being tested that try to modulate the expression of PNPLA3 or HSD13B, which is a protective allele, in order to understand whether this will change the natural course of the disease. So does genotyping for main polymorphisms associated with MASLD help identify patients in need of pharmacologic therapy? Do you want to comment on that?
Yeah, no, thank you, Vlad. You very eloquently described the current sort of state-of-the-art where things are in terms of published data on PNPLA3 genotype and a risk of liver disease progression. And then we are seeing in trials where we have data available that the response might be different. So there are 2 trials where we have really good data, but we have also emerging data from the FASN inhibitor trial with denifanstat, and looks like response to denifanstat, which is a FASN inhibitor, is also not different with the PNPLA3 genotype. So it looks like this genotype is associated with lipid packaging and dense packaging of lipids within the hepatocyte. So if you have a drug targeting the hepatocyte directly, such as Resmetirom, such as denifanstat, what you could do is you could potentially not have an impact of this genotype on treatment response. Now, if you have a treatment that is not affecting the hepatocyte, particularly lipid signaling directly, then what you will see is that you will continue to see the impact of this genotype. Because you can imagine we're born with certain genes, and most of our patients have had this effect for over 50 years because it's a 50-year-old generally in our phase 2b trial. So it's a cumulative effect of 50 years of carrying that genotype on your hepatocyte, and when you start a drug, you may not be able to get rid of that if the drug is directly not acting inside the hepatocyte. So I think that's a important thing to understand. Vlad, you pointed out in the last bullet that there are other therapies that are in play where people are looking to first test the genotype. If you're PNPLA3 homozygote, then you go into a certain trial for gene silencing approaches with either an ASO, which is an antisense oligonucleotide, and that's a program, combination, collaboration between Ionis and AstraZeneca, which is now in phase 2b, where we're seeing if silencing PNPLA3 would lead to improvement in liver histology. There was also a parallel program where we had some data in a letter to editor in New England Journal of Medicine looking at the Arrowhead PNPLA3 siRNA that showed improvements in PDFF with silencing PNPLA3 in a short-term proof of concept study. So I think this is becoming a really interesting area where we might move into precision medicine. Another aspect of it is, could you have a different lipidomic profile? If I have 10 patients with PNPLA3 homozygosity with the risk allele and then 10 who are wild type, could they have a different lipidomic profile? And the answer is yes. They have a different lipidomic profile in the blood. They have a different lipidomic profile in the liver. And so I think it can give us clues of developing specific biomarkers as we start going into precision medicine and better understand the effect of genotypes. And there are other genotypes as well, such as HSD17B13. So that particular genotype has been shown based upon large study done by Regeneron and then subsequently by other colleagues that if you have HSD17B13, you could be protected from liver disease progression or liver injury. So we are seeing some genotypes increasing the risk for liver disease progression and other genotypes being protective. And both of these are now being exploited as treatment modalities in NASH drug development.
Thank you, Rohit. So let's continue here with another question. According to expert recommendations, what is the most appropriate next step for Christina, who has a BMI of 26 kilograms per square meter, elastography values of 12 kilopascals, BIP4 score of 2, and no evidence of cirrhosis? So would you continue to monitor her? Would you initiate treatment with a GLP-1 in the slightly overweight patient? Would you initiate treatment with Resmetirom, or would you combine both of them?
Let's see what Team Green does. Excellent.
Okay, I don't know who's the referee for that. we still don't have the correct answers, but
It
it's a very
depends on the
balanced
trajectory.
referee. Yeah.
It's the trajectory.
Yeah, right.
There are 3 times.
Something happened that the green team had some good discussion, I guess, with the referee, because now we're equal. So we'll see. So what would be the next step for Christina? Here is just a reminder of the different drugs that are in development now. And please note that there are some, but fewer studies for cirrhotic patients. It is an interesting question, though. So obviously, the question would be, do you always need to initiate a cirrhotic trial once you have a NASH molecule? Obviously, there's a lot of benefit if you're able to prove an impact in cirrhotic patients. A benefit in terms of registration ability, a benefit in terms of reimbursement, a benefit in terms of overall clinical benefit for the patients. But do all therapies that address MASH would necessarily work at a cirrhotic stage? That's an open question. Nonetheless, here are some of the drugs we've been discussing extensively this morning about them. Some are in phase 3. Others have shown promising results in phase 2B. I'm not going to go into detail about those, but I think the main message here is that hopefully in the next 5 years we'll have more and more resources to treat MASH, and those resources could be individualized to the patient profile in a much more precise way than what we've been doing today. So I guess this sort of gives you an overview of where we are in terms of how you identify patients that can be treated in 2025. And now we go to a more complex question, which is how would you treat the liver disease within the context of all these metabolic comorbidities that the patients have?
That's great. Thank you. So we're going to look at our second case, Richard, a 68-year-old white man, body mass index of 35 kg per meter square, 7-year history of having type 2 diabetes, hemoglobin A1C is 8.1%, eGFR is 57, and serum ALT 72, AST of 65, GGT of 119, 9-year history of obstructive sleep apnea, LDL cholesterol is 85. Liver biopsy 2 years ago showed stage 2 fibrosis. This patient has received vitamin E in the past, but no effect on his AST or ALT, currently taking atorvastatin and metformin. Now, if you look at GLP-1 analog and their impact on cardiometabolic outcomes, here we can see the risk reduction compared to placebo with semaglutide over 48 months. And you can see there's a significant reduction with semaglutide in terms of CVD risk in adults with obesity. And this patient of ours has obesity with body mass index of 35 kg per meter square. And to the right, I'm showing you data with tirzepatide, a GLP-1 and GIP analog, and you see a significant reduction in future risk of cardiovascular events. So both of these drugs are giving us these reductions in cardiovascular events that are important and clinically significant over several years of treatment. We look at body weight improvements. With semaglutide, you can see about 15% improvements over 68 weeks of treatment, and with tirzepatide to the right, you can go down to 22% improvements as well with the higher dose of 15 milligram. So you can see both of these drugs are giving you pretty substantial weight loss, along with, in the previous slide, with cardiovascular benefits that you're also noticing as you follow them long term. So what is the impact of diabetes control on progression of liver disease and mortality? Vlad, you've looked at a lot of these data, and as editor of Journal Hepatology, a lot of these papers are coming to you. How do you really assess whether diabetes control, in your opinion, has an impact on liver disease progression and mortality?
That's not an easy question to answer. First, most of the studies that therapeutic trials in NASH have excluded patients with not well-controlled diabetes. So I guess that it is quite clear that diabetes itself has a pro-fibrotic effect in patients with MASH. So the more severe, the fact that a patient has diabetes makes it that the liver disease is more severe. You might think that, therefore, by controlling diabetes, you might improve the liver condition. In fact, it is very hard to prove because we don't have usually the history of these patients' diabetic control before they enter into these trials, whether therapeutic or natural history studies. So it's very hard to understand. So all patients are diabetic, fine, but some are very well controlled, others are correctly controlled, others not well controlled, and that can change from one year to another. So having a whole history, some sort of like area under the curve for the control of diabetes is not available for most of these patients. So beyond the fact that it's clear that diabetes makes things worse, it is very hard to have a quantitative assessment of that relationship. There are some data showing that HbA1c values are associated with higher HbA1c values with more fibrosis. We don't know whether correcting diabetes would have an additional effect on the liver. It is not only the trials are too short for that, but also the confounding impact of weight loss is also a major problem. So I'm not sure we have a straight answer to that. But in the end, does it really matter? What matters for a patient is a sort of a holistic approach, so controlling diabetes is critical anyway.
Thank you for your viewpoint, Vlad. I think it's really important to put the ideas that you put forth in perspective in terms of, the trial design, what type of patients are coming in those trials, and how we can really assess the impact of hemoglobin A1c on disease progression. Let's do a polling question. Which of the following most closely represents the histologic response seen with semaglutide in the ESSENCE trial in the phase 3 results that were recently presented at AASLD? Number 1, resolution of MASH, but no improvement in fibrosis. Number 2, improvement in fibrosis, but no resolution of MASH. Number 3, both resolution of MASH and improvement in fibrosis. And number 4, cirrhosis regression. Please vote. Okay, Team Yellow is winning again with 40 points versus 30 on Team Green. But this is good. I think it's a good fight that we have between.
And yellow is the color of the liver, right?
Yes.
Bile,
absolutely.
so it's normal that in a liver conference we're ahead. So, okay.
Oh, sorry. Let's see here. Okay, this is looking at the question we just asked on efficacy of semaglutide in MASH in the phase 3 trial. To the left, I'm showing you resolution of MASH with no worsening of fibrosis. In yellow is semaglutide 2.4 milligram, and the biopsy done at week 72 compared to placebo was statistically significant at 62.9 versus 34%. And then improvement in fibrosis was 37 versus 22.5. And then combined resolution of NASH with improvement in fibrosis was also noted, 16% on placebo and 32.8% on the semaglutide. So overall results look very promising, and I think we can see that patients could benefit both on the NASH resolution and also on fibrosis improvement.
Can I comment a bit on that?
Yes, please.
So it's interesting to see. So our whole understanding of this disease is that the activity of the disease, which is captured into the steatohepatitis component, is driving fibrosis evolution. And it is interesting here to see that you have a higher rate of steatohepatitis resolution than on fibrosis regression, which probably validates this hypothesis and tells you that it first clears the liver from activity, from inflammation, and then it will have an impact on fibrosis. And if that is true, then probably treating even beyond 72 weeks might have an even higher antifibrotic effect. So this kind of sticks very well, these results, with our understanding of the disease. The other thing I wanted to say is that the placebo rate is very high, and there's nothing to do about that. I think it has to do with the pathologists and the way they read the slides. But what's interesting here is that when you look at the combined effect on both activity and fibrosis, then you start really reducing significantly the placebo response rate, and then you see the efficacy of the drug much more clearly, which is the case here on the right side of the graph. So,
yeah, no, I absolutely agree with you. I think the only caveat for the combined endpoint, it looks good to have it, but we just need to have an extremely well-powered study. Because if you had only 100 patients in the trial, then the combined endpoint may not be statistically significant. So having a really good power is really important because you would have greater precision around those estimates. Great discussion, Vlad. Thank you. This is looking at Synergy NASH, again, phase 2b trial that we published last year, looking at tirzepatide with 3 different doses, 5 milligram, 10 milligram, 15 milligram, sub-Q weekly compared to placebo. You can see that there is a significant improvement to the left on resolution of MASH without worsening of fibrosis compared to placebo, and also decrease in fibrosis stage without worsening of MASH to the right compared to placebo. One thing that we noticed, and we've discussed that, we don't see a big treatment effect delta or dose response as we go from 5 milligram to 15 milligram. I don't know, Vlad, if you wanted to say a few things about that.
No, the question here is, obviously this study was only 52 weeks, the previous study was 72 weeks. Do you think that changes a lot in the response rate you could see?
Yeah, I think it's plausible that you could extract potentially greater benefits as you extend it to 72 weeks on 2 ideas. One, that we would see continued weight loss with tirzepatide, because you could get up to 20% weight loss between week 52 to 72. So that's a possibility why you would see that. And that would actually potentially boost on both sides. And I think the key thing is, making sure the patients stay on treatment while we are pursuing the 72-week study. Thank you, Vlad. Is there a benefit to using GLP-1 receptors in patients with more advanced disease, including cirrhosis? I think this question came up earlier also. Vlad, what do you think about using this GLP-1 analog in patients who have cirrhosis and have obesity and type 2 diabetes?
It's very hard to tell because we don't have good data on that, and the trials that were performed were on a small number of patients, limited duration, the ones semaglutide you and others have published. Not only it was a small number of patients, also it was 1 year, but it took 6 months to get to the full dose. So clearly the exposure was insufficient. The big uncertainty, so first of all, no cirrhotic trials were positive ever in this disease. The uncertainty here is, what do we call cirrhosis? Is it the very early cirrhosis state where you have mostly fibrosis but not yet portal hypertension? Is it the more advanced cirrhosis stage where you can start developing clinical complications of decompensation? I don't think these two extreme parts of the spectrum can be treated the same way and with the same type of drugs. Admittedly, drugs that do not have a direct effect on the liver might only work at the early part of the spectrum by correcting the metabolic milieu. If the more you move into more advanced cirrhosis, the less the probability these drugs might work. But we don't know as far yet how.
Thanks, Vlad. That's a really important point that you bring out. What are your thoughts regarding sarcopenia that potentially could have an impact in a patient with cirrhosis with continued treatment in the setting of advanced disease? Any thoughts on that?
So in general, sarcopenia was associated with more severe steatohepatitis, more severe fibrosis. And obviously there is a risk. First, these patients are older. They already have cirrhosis. They might not have a good nutrition status. And if they lose a lot of weight, obviously they are at risk of having sarcopenia. The good news here is that if you do a good nutrition measures and a physical activity program, even in cirrhotic patients, you might limit the impact of sarcopenia and actually even improve the liver condition, including portal hypertension. Some studies have been done with that. So clearly it is a risk, and you need to be more careful in looking into the other adjunctive measures, such as physical activity in these patients.
Great, thank you. It's a polling question for you. For approximately what percent of patients with MASH and metabolic comorbidities do you currently prescribe a GLP-1 receptor analog? None, 25%, 50%, 75%, 100%, and I do not manage patients with MASH. That's great. Looks like Team Yellow is continuing its streak for winning. That's awesome. But Team Green, keep it up. You're doing great. I'm proud of you.
So just to comment on that, it's a fascinating question because it might depend a lot on how you practice and where you practice. So for instance, you practice on the West Coast, I practice in Europe. We don't get to initiate GLP-1 or any incretin therapy because of the comorbidities. The way the health system is structured in France is that healthcare is very fragmented between different specialists. So only the endocrine or diabetes specialist would initiate that type of treatment. I would initiate treatment that is clearly targeting the liver. So since we don't have this responsibility, maybe we should expand our prescribing, abilities or practices to this type of drugs. But for the moment, they're not in our hands. So the question is interesting in the sense that it reveals also different patterns of practice. So I don't know, do you prescribe this type of drugs for the metabolic aspect of the disease, or do you let that to your colleagues?
Yeah, I think you're absolutely right. In the United States, generally, a clinician can prescribe any medication unless it's specifically there's a requirement that has to be prescribed by a specialist. In our practice, we can prescribe a GLP-1 analog such as semaglutide or Trulicity or tirzepatide for its indication for obesity, type 2 diabetes, and now obstructive sleep apnea if our patient has it. And so, some people do prescribe and others don't within a hepatology or a GI practice. As a gastroenterologist and a chief of gastroenterology, I also view obesity as a GI disease. And so a lot of programs have obesity built into it. From a health system perspective, we have a metabolic health program in primary care, but also in surgery. So you can see you could achieve or get different care in terms of GLP analogs, maybe in 4 or 5 different clinics within a health system. And that's, I think, much more common here. What are the benefits and limitations and effects of bariatric surgery on pharmacotherapy decision-making in patients with NASH? Now, Vlad, are you using or referring any patients for bariatric surgery now in your practice?
We do, but the ultimate decision is not at all in our hands. It is in the hands of we have a very strong nutrition department. They perform more than 700 bariatric surgery patients. They published on it. I'm surprised on how difficult that journey of the patient is towards getting a bariatric surgery. They're not eager to do it in anyone. I mean, in an academic center. I think private practice might be different. But
yeah.
Really, they're not. A lot of patients get turned down. So there's not much I can do. So I would, second, you will show the next slide. It doesn't look like the effects, especially on fibrosis, are that spectacular. But I would like to return the question to you. Given the difficulties in getting the patients into the system and having the bariatric surgery performed, do you think that these new drugs that achieve between 20 and 30% of weight loss, would that be a threat for the bariatric surgeons in the future?
Yeah, I agree. In fact, we don't have any problems getting people through to bariatric surgery. So but I'm seeing that those referrals are really drying. I am not, sending a patient for bariatric surgery unless the BMI is 55, 60, where I think that the patient, would benefit from a long-term approach, and the therapies can have a deleterious effect. So I think in that setting, for a patient with a BMI of 35, this patient I presented, I would not be referring that patient for bariatric surgery in my practice currently. And there's a big change and shift in the United States now. These are some of the data that Vlad was alluding to. This is from your group, right, from Raluca, looking at bariatric surgery improvements in fibrosis among patients with advanced fibrosis. And you can see that these patients had, stage 3, stage 4 fibrosis, and then a follow-up, you see, significant improvement, but 28% of patients had cirrhosis at baseline, and then 19% still had cirrhosis at follow-up. And this is looking at biopsy at about 3 years in general, 156 patients. So, things improve, but in patients who have stage 3 and stage 4, if we take the entire data published in bariatric surgery on histology, I think cumulatively we have less than 1,000 patients with stage 3 and stage 4 fibrosis in those studies. So I think it is important to see, but I do believe that over 5 years, they would show benefit. But with current therapies that are emerging, this is going to be less and less used.
So two things here. First of all, as you said, surprisingly, for these people who are very obese and very metabolic, surprisingly, most of them, at least in the series that are published, have very, very low level of liver damage, stage 0, stage 1 fibrosis. You might think there's a bias in recruitment because those with advanced disease for the longest time were not referred to or were declined surgery. But it's striking to see, and therefore, most of the time when people brag about the effects of bariatric surgery, they're talking about fibrosis reversal in people who are stage 1.
Yes.
That doesn't mean it's very effective. That was the thing I wanted to say, and I want to say something else, but it'll come back to me later. Go ahead.
Thank you. Appreciate it. Polling question. What would be your next step for Richard, who has obesity, poorly controlled type 2 diabetes, stage 2 fibrosis and biopsy, chronic kidney disease, and is taking a atorvastatin? Number 1, continue to monitor after discussing lifestyle changes, initiate treatment with GLP-1, initiate treatment with Resmetirom, initiate treatment with both Resmetirom and GLP-1 receptor agonists. Team Yellow wins with 60 versus Team Green with 40. Excellent, Team Green. This is your highest score so far. Keep it up.
So can I ask you, Rohit?
Yes.
So the other thing that we can learn looking at this bariatric surgery data, especially our data, but others as well, that show that 45% of people with advanced fibrosis still have advanced fibrosis. If you measure with a NASH CRN, which is an imperfect score for that purpose, but they still have advanced fibrosis, 5.5 years in median follow-up after bariatric surgery. So immediately then you think, okay, all the talks we had this morning, we're not very happy with fibrosis reversal rates of around 20, 30% after only 1 year or 1 year and a half maximum. Don't you think that we're asking too much from these drugs, knowing that a dramatic intervention such as bariatric surgery, which makes you lose 30, 40 kilograms, remission of diabetes, remission of hypertension, no longer need for therapy, has a much lower rate of response than these drugs. Aren't we not asking too much from this therapeutic drug?
Yeah, no, I think you're absolutely right. It's really, race to the subpart H endpoint and, trying to get there. And these trials are very expensive. And therefore, the other caveat that's also important is there isn't a placebo arm in many of these bariatric surgery, studies. So how placebo is treated. So I think the rigor that we see in phase 2b and phase 3 trials for pharmacologic therapy, I think that rigor is not seen in bariatric surgery trials because those are predominantly investigator-initiated. So let's look at our case again. What would be your next step for Richard? How would your recommendation change in 5 years if his MASH markers and fibrosis do not improve? So future of therapies to target MASH and cardiometabolic comorbidities, looking at, there's a phase 2 trial that's ongoing, looking at semaglutide plus cilofexor, which is a low-dose FXR with forsocostat and ACC inhibitor, so liver-directed therapy with a GLP-1 analog. There is data on NITs that things look better with combination versus monotherapy. Then survodutide, which is a GLP-1 plus glucagon agonist, where you can see more glucagon-based effect on the liver. And this is now, as Vlad previously showed, is in a phase 3 program already and has a breakthrough designation for non-cirrhotic MASH. And then semaglutide plus zalfermin, and so a phase 2 trial is ongoing in patients with NASH and stage 2 and stage 4 fibrosis, and the results will be coming out in the next few months, and really looking forward to seeing if combination approaches would yield a better treatment response on fibrosis improvements. So in conclusion, Resmetirom is the first FDA-approved therapy for MASH. Eligible patients have MASH with stage 2 or stage 3 fibrosis who do not have cirrhosis. In addition to established NITs, such as FIB4, transient elastography, and ELF, new NITs are emerging to help stratify fibrosis risk in stage. There are genetic components that indicate risk for progression in patients with MASLD, and GLP-1 receptor analogs continue to be a treatment option for patients with obesity, type 2 diabetes, and cardiometabolic comorbidities, and have shown efficacy in treating MASH as well. Bariatric surgery can be considered for patients who have significant comorbidities such as severe obesity, type 2 diabetes, and MASH that are non-cirrhotic, in my opinion, and then potentially could be used. But in my practice, that's really for patients with extreme body mass index of, say, a 50 or 45 kilogram per meter square or higher. Next slide. Okay, so post-it question 1. I think this is what we covered earlier. Which of the following would be useful for determining whether Christina is eligible for Resmetirom? And I think many of you answered that correctly. Will we get the results? Okay, so let me press this and see. Next slide. And 67% of you correctly identified that is transient elastography or liver stiffness on FibroScan for 12 kilopascal. That's the sweet spot between 10 and 15 kilopascal that a patient has, stage 2 fibrosis, or higher. So I think that's looking pretty good. This is before and after. I think 22% chose the ELF score. I'm so glad that that was a learning pointer here, that 11.3 is associated with cirrhosis. So you don't want to treat a patient who you think has cirrhosis and 20% chance of decompensating over the next 2 years. That's what 11.3 is reflecting. That's good. Excellent. Let's look at post-test question 2. According to expert recommendation, what is the most appropriate next step for Christina? BMI of 26, TE 12, FIB4-2, and no evidence of cirrhosis. These are our options. Let's take a look on the results. So 60% shedding treatment, and I think there's an uptick there. There were 10% would be reasonable, the BMI of 26, to consider Resmetirom alone as a treatment option, and that's why that's the correct answer for our CME program.
And also, I think the other thing that it's clear here is that you can always say, let's try lifestyle changes and diet and lifestyle changes. But I think in a patient who already has a liver stiffness value of 12 kilopascals, I think it's useless to start with that. At best, you would just delay an effective treatment. At worst, it won't work because the patient is already very advanced. So I think, to me, how I understand it in clinical practice is that you should always recommend that, but you should not delay specific therapy, either with semaglutide or resmetirom, in patients who are already at a more advanced stage. You can delay it in people who are F0, F1, but not in those who are more advanced.
I completely agree with you, Vlad. Question 3, which of the following most closely represent the histologic response seen with SEMA in ESSENCE trial? Let's vote. Uh, 83% there. So looks like this one, everybody got it correct. I'm so glad that the entire team is up to date on these. So excellent job. Let's
take home message: a third of patients treated with semaglutide improve both activity and fibrosis in the same patient.
Let's look at what would be your next step for Richard. It's poorly controlled type 2 diabetes, stage 2 and biopsy, chronic kidney disease, is taking atorvastatin. Let's vote. Good, 61% choosing GLP-1 analog in this particular case because of type 2 diabetes and obesity in this patient, and already with CKD. So that seems like a good option. Some of you chose number 4, which is initiate both Resmetirom and GLP-1 analog. And I think we discussed the idea about maybe pick one, start with that, see the response. You know, you have time. It's not like if you didn't treat them in the first year, things are going to change for stage 2, stage 3 in that setting. So I would pick one therapy. Let's take a look. Post-test 5, approximately what % of patients with NASH and metabolic comorbidities will you now prescribe a GLP-1 receptor analog? These are your options. Let's take a look. Excellent. So I think a lot of people are not prescribers in the audience, but congratulations, you know the data very well. I'm proud of you. Let's go on with question and answer. We have 2 minutes available to us, so we'll try to cover as many as we can possibly do.
So someone in the audience said that they have many patients in the clinic with high ELF, but low transient, low stiffness, measured by FibroScan. How do you think, is there a good correlation between these two, ELF and FibroScan? And if not, does ELF increase because of other factors than liver fibrosis?
Yeah, I think that's a common thing that you might see in a patient with type 2 diabetes. So I think that discrepancy can be there. We have settled in our hands. MR elastography is much more precise and has a highest diagnostic accuracy for a fibrosis assessment, so we usually use that for tiebreaker and typically reserve the liver biopsy if the patient cannot have that. So that's typically what we do, and based upon the MR elastography, we utilize the tiebreaker.
So someone in the audience complains that MRE and MRI are expensive and not always covered by insurance, and also that transient elastography has issues with reproducibility and between different measurements. So they ask us, what do you recommend then for monitoring response to resmetirom? And maybe we went a little bit too fast over those data, but I think the ASLD guidance that was published recently is a very good paper to look at. So basically, you have to use what you have. So the ALT response, if it's a dramatic decrease, that's a good thing. If transient elastography decreases by more than 25% is a good thing. The best marker of efficacy in the Maestro outcome, in the Maestro NASH trial, was PDFF. So if you had so that means you have access to PDFF before and after. But PDFF, less than 30% reduction, almost nobody responded any better than placebo. More than 30% reduction in PDFF, people responded, but not all of them, only half of them. So it's not very good for predicting response, it's good for predicting failure. Now, the ASLD guidance insists upon elastography and ALT, but we know that in the case of resmetirom, those are not very good markers of.
Yeah, one thing I would suggest that you do a baseline fibroscan before starting treatment with resmetirom. Do not repeat it at 6 months. And that will take away the problem that you're having. Repeat it at 1 year. And that would be the way to assess. You can do ALT, AST, and other assessments that you clinically do and commit to a 1-year treatment unless you see a problem that the patient cannot tolerate. 1 year, do your fibroscan assessment. And if you see the fibroscan is not improving, then that would be a time you can call Vlad and I, and we can tell you what to do. So with that,
last question,
Sure.
short question, short answer for you. Do you think PNPLA3 genotyping will become more common in practice as more therapies become available?
Yeah, I think over a 5-year horizon, they will become more common, and we might be using them in our clinical practice over a 5-year time point, but next year, probably not.
Thank you very much, Rohit. Thank you all. And see you at this afternoon session.
Thank you.
So I pick up the news like I said I would. Drop my